what I do, so that not everyone is familiar with having, a pharmacist around a clinical setting, and then we go from there. So I'm sure that, we all see pharmacists in our, community pharmacy, in a hospital, they prepare all your medications. What many people are not familiar with is just people like me, we're called clinical pharmacists. And although I've listed where pharmacists are, they are in many different areas and places that they work, like industry, academia, etc. But mainly where I am, I'm a clinical pharmacist. I'm specifically an outpatient setting in neurology. But as I said, it's a profession that allows us to be in many different areas of healthcare. So as a clinical pharmacist, what I do when I'm in neurology, my job is to collaborate with our neurologists, our trainees, nurses, mainly, obviously, because I'm a pharmacist in the area of medication management and medication use. For the sake of this group, we are going to focus on epilepsy and headaches, but it's not only, my role is not only limited to these two diseases. Anywhere there is medications and use of drugs, that's where I am. And the list of our anti-seizure medications is, I'm sure it's been growing. On the top left, you will see many medications are old generation anti-seizure medications. They used to be called anti-epileptic drugs, but these are anti-seizure medication. Basically, these are not the cure, as we all know, they just prevent seizures. The interesting thing is that the older medications, if we start with phenobarbital, that was approved such a long time ago, we still use it today. It's probably one of our very great efficacious medication that is being used today. And then a series of drugs came out to the market in the 90s, still in practice. And then the last group of medications, with the last one that was approved, Xcopri, in 2019, and we have started using it. Now, the first group of medications that there are still in use, like drugs like phenytoin, carbamazepine, valproic acid, they're great medications. But what has happened with the newer medications, the way they have been sort of manufactured, that they have given us this opportunity to have less, perhaps, drug-drug interactions. That's one of the things that I play a significant role in, and less frequent use of them. For example, medications that you had to take in the older generation 2 times a day, 3 times a day, we do have medication with the new generation that you have to take them less often. So these medications, obviously, they all have different pharmacology, different mechanism of actions. I try to stay away from technical terms, but we know what they do as a whole. They basically they work to quiet down the brain that it's overexcited and causes seizures. So some of them work on ion channels that are on the neurons. And some examples like sodium channels. We have a lot of drugs that work on sodium channels, some on calcium channels. And then there are drugs that work on the neurotransmitters that are in the brain that sends messages between neurons. Some of the neurotransmitters cause excitation in the brain, some cause inhibition in the brain. So they go after those areas to sort of basically to decrease this excessive electrical activity or excitation of the brain, of the neurons, that ultimately causes seizure in the brain. Some work specifically for some type of seizures. For example, I'm sure you're familiar with these terms, partial onset seizures, focal onset seizures. They are specific for those type of seizures. We are lucky that we have medications that work for both. They have broad spectrum medication activity and work for both general onset seizures or focal or partial onset seizures. We know that there are a few that may make other type of seizures worse, and we need to know which ones to avoid for a patient, and that if a patient has a specific type of seizure and we know this medication can cause that seizure worse, so which ones to stay away from. Some we refer to them as inducers. These are the conversations in the back end that, for example, I'm talking to our physicians or physicians are talking to each other about when we are selecting medications. Some of them are called inducers. And what that means is that if they're combined with other drugs, they can can result in decrease or diminish efficacy of the other drugs. Some are considered inhibitors. And what that means that if they're combined with this specific other drugs, they can increase or enhance concentration of other drugs. Basically, there is risk of toxicity or adverse events. Some of them, like any other drugs, can cause allergic reactions. And I put here that can have cross-reactivity. What it means is that we know we have a group of drugs here that if our patient has an allergic reaction to this one, there's a very good chance that because of the way the drug is, its pharmacology, that they can also have a serious adverse event or allergic reaction to the second drug. So as a group, when one allergy has been reported, as a group, we stay away from that group of drugs. And then when they combine with each other, is that they interact with each other. I mean, if your patient ends up being on 2 or 3 anti-seizure medications, there's a significant potential that these medications are known to cause drug-drug interactions. So it can cause interactions within themselves. It is important because, for example, we do have patients who have other, diseases, other medications that they have to take. And for example, the other day we had a patient who was on a medication for his heart. So if you have to pay really close attention to make sure that we don't give that patient a medication can diminish the efficacy of the other drug that they need. Some you may already notice that some of them have very unique adverse events that we always keep in mind if we are selecting a medication. For example, we know valproic acid can cause weight gain. So for a patient who's already battling and struggling, weight will not be, the most appropriate medication. We always keep those things in mind. We do have medications that cause weight loss. For example, zonisamide is one of them, topiramate is another one. We know that it causes weight loss. Again, on the other spectrum, if we have patients, and we have had patients who are on the, as far as the weight is concerned, they're on the lower side and they want to gain weight. So these are the medications that will not be appropriate and the best options for them because they may continue losing weight. The way we look at these medications, the way we divide their adverse events, we divide them into 3 different categories. They are dose-dependent adverse events. That the higher your dose is, the higher your concentration is, and that you may experience those adverse events, things like being too sleepy, being too tired, being lethargic. Sometimes the level is too high, having double vision. I mean, a patient comes in and says, I have double vision, we need to check that what is the level of this medication. Causing problems with balance or ataxia, affecting your balance. Those are dose-dependent adverse events. Some of them are rare, and they're called these idiosyncratic adverse events. We call them idiosyncratic because really we don't know why one patient has it and why the other one doesn't have it. But they are rare. Luckily, they are rare, but very, very uncommon. But they can happen. And then the long-term adverse events of this medication that we look at, what are the chronic adverse events of this medication? If you keep this patient on a long-term, epilepsy sometimes it's a lifelong time medication. What are the possibilities? What kind of adverse events do they have? Is it going to affect their bones? Is it going to cause them, other issues? So we always have to keep those in mind when we're selecting the medication. And then the biggest issue, because we do have a lot of women who are of childbearing potential who have epilepsy, and then which medication we certainly have to avoid if in a young woman who's planning pregnancies. So patient education plays a significant role here. So what is the appropriate use of this medication? What do I expect? What to expect? Because initially when we start these medications, we always start on the low end of the dosing. What is the smallest dose that we're going to give this patient? And then we build it up as we need it. The goal is to get this patient's seizure under control with the lowest amount of medications. So the question is, what do I expect? At this dose, what's going to happen to my seizures? We have had in some occasions that patients didn't see much efficacy or improvement with their seizures because we were on such a low end that they stop taking it. The low end that we start the medication is to make sure that the patient can tolerate the medication, that they don't have adverse events, and these medications have to be built up slowly. So asking what to expect, and yeah, it's a very slow dose, and we're hoping that if you tolerate it and don't have any adverse events, we're going to start gradually building it up. What am I going to monitor? What to look for? When do I call? When do I ask for help? What happens that I need to call you? And as part of this, one of my role, and a very important role, multiple times actually this happens when a patient comes to the clinic, that somebody's asking you about your other medications. And the term for this medication reconciliation, what are you taking, including other medications that other physicians are prescribing for you? So the goal is to anticipate, prevent, and monitor for drug interactions, basically by looking at, this is a technical term, pharmacokinetic properties of each drug. Basically what it means is movement of drugs in the body. Absorption, how will this drug get in and how will it be absorbed? The drugs get absorbed in different areas. Where does it go? Distribution, where is this drug going to go? Metabolism, how is it going to get out of my body? How is it going to metabolize? Majority of our medications get metabolized or broken down in the liver. And what happens to them after they have been broken down? How are they going to leave my body? So those are all important things that we look at, again, when we are selecting medications. Again, one important part of this sort of work is what other medications the patient is currently on, as I just talked about. What other conditions or comorbidities this patient has that may affect this drug. For example, if you have a medication that is mainly, and we do have medications that they're not broken down in the liver, that basically you take them and you literally excrete them through your kidneys unchanged. Nothing happens to this drug. You go to the bathroom and the drug is just going to use your kidneys and then it will leave your body. So now if we have a patient who's got issues with kidney functions or diminished kidney functions, then we have to keep that in mind, that what is the most appropriate dose for this patient if the kidney function is at this level. Is the patient an adult or are we looking at a child? Children use much more drugs than adults do. Their metabolism is much faster than adults are. So milligram per kilogram, their doses usually are much higher than adult patients. And then depending on if you're looking at an adult or a child, your dose will be different. And then, as I said, they have a much faster metabolism than an adult patient. As we get older, our metabolism slows down. As I just talked about, is this patient a woman or child in potential? And if she is there a plan for pregnancy? So we talked about the term pharmacokinetic properties of a drug. And then the other term that is very commonly used in pharmacy is pharmacodynamics property of the drug, which basically what we're talking about is body's biological response to this drug. What is body going to do to this drug? Which we talked about drugs, the drug metabolism. And then the other thing that we look at is what if the patient is on more than one drug for this condition? We do have many patients that, for example, for treatment of their epilepsy, they're on multiple medication, 2 or 3. And unfortunately, we do have patients who have bad epilepsy or what is called refractory epilepsy, hard to difficult to control epilepsy, and they may have on more medications, 4 medications. For example, if you look at this person and say, well, 2 drugs that can both cause sedation, what will going to be the impact on the patient and how are they going to tolerate it? At what dose we're going to be tolerating it? 2 drugs both have levels that are at the end of the therapeutic range. When you go see your physician, we can order for the levels of these medications for all the drugs that we have. And basically what that means, that will tell the physician or tell us is that at this dose that you're taking, what is your level? How much of this drug is in your blood? And then we have therapeutic ranges, appropriate levels, appropriate ranges. So imagine or consider that we have a patient that's sitting at the high end of this therapeutic range or this appropriate level. What if we add a 3rd drug, or we have to add a 3rd drug? Then what is the relationship of this 3rd drug to these other 2 drugs? as far as drug-drug interactions are concerned, and then pharmacodynamic interactions, meaning that if the third drug also has a tendency to cause sedation, then not the patient is on 3 medications that does this, then what dose should we start the patient with? So those are important conversations to have with the patient. Maybe added third drugs. Says, yeah, I anticipate that this is going to happen. Or you ask what's going to happen if you're adding a third drug or second drug. One of the other diseases that is common with this population, I'm sure you already know that, is headaches. So, and we do see, when we see a Sturge-Weber syndrome patients in our clinics, so the two, because it's neurology, so the two things that we talk about, epilepsy management and headaches. You may already know, we all know, that there are many over-counter options, and usually this is where patients start. I mean, they go to pharmacy, they take medications, they talk to the pharmacist, they take something over the counter. There are many prescriptions, both for abortive therapy, but what I mean is that it's going to stop my headache now, or immediately, or quickly, or that for preventive treatment, that I have so many headaches per month that I have to take a drug every day to prevent my headaches to start with. So if somebody comes and says, oh, I get 2 headaches a month, that's not a patient for preventive management. So you get headaches 2 times a month, you can use, ibuprofen, acetaminophen, prescription abortive medications to stop your headaches, stop you with headaches. But if somebody has headaches every week, sometimes twice a week, these are the patients who are appropriate to give them medication every day to prevent these headaches. So at least two others that actually have FDA indication for headache management or headache prevention. Valproic acid is one of them, topiramate is the other one. You might be familiar with these medications. For migraines, I mean, there are so many medications, prescription medications. There are 7 triptans. I mean, the most famous one is Emitrex or sumatriptan. You might already be familiar with it. There are 7 of that class in the market. They come in different formulations, tablets, nasal spray, injections. There's another class of drugs that we use for headaches, dihydroergotamine, that they have 5 different formulations. So there are many prescriptions available. What has happened in the past few years, that there's this new class of medications that have come to the market. I honestly cannot turn on the TV and don't hear about this medication. I'm sure you have heard of this medication that I have listed here. There's so much advertisement about them. If you haven't used them, you probably Nortec, Calypta, Aimovig, Ajovy. These are new from medications for headache management, migraine management, headache management, that they have come to the market in the last couple of years, and they're becoming very popular. A new version of it that Pfizer just got approved, it's not available yet, for acute, abortive treatment of migraine, which is anticipated to come to the market in July, is the first nasal spray of this class of drugs that is going to be available for patients. These medications have completely different mechanism of action compared to older medications that are already in the market. They go after this protein. The protein is called calcitonin gene-related peptide, or GCRP. So this is a protein that gets released when somebody is having these headaches and causes a lot of inflammation and vasodilation in the brain, basically expanding the brain blood vessels, which ultimately causes the headache. So these new medications basically go after that protein. They either bind to that protein, prevent it from working, or bind to its receptor, prevent it from working, so preventing this inflammation of vasodilation in the brain, helping with migraine headaches. So for migraine headaches and headaches in general, there are this new class of drugs that have become very, very popular and have been used. So there are many, many options for headache management, which is great for patients. Each has a level of different adverse events, and then specifically which medication should be used for what, depending on their adverse events. For example, one of them can worsen hypertension or blood pressure. So if somebody already is bad on blood pressure, that's not the appropriate medication for that person. So you have to look at the patient and see which medication is good for this patient or can use. And then the other things that I'm a pharmacist, we battle on a daily basis is patients' insurance, that what this insurance or what their formulary allows this person to use. So as a whole, with these two diseases, basically my role is, as I said, to assist with drug selection, again, based on the drug's properties and patients' specific characteristics. I do a lot of patient education, provide a lot of written medication schedules. I follow up anti-seizure levels, blood work screening, patients call our clinic a lot with questions and side effects and other questions. And then responding to all those messages about medications as a whole, and then responding to medication questions that come from our team, physicians, etc. And then medication access, again, helping patients getting their medication is a big role that I have. So what I wanted to talk about in the last, for the last few slides is, as a patient, what to consider. So always, have to have, it always helps us so much that the patient either have their medications with them, the medications follows with them, or they have a list of their medications. Now, that includes over-the-counter medications. Sometimes our patients don't consider over-the-counter medications or supplements, but including all of those. And then asking for, written instructions. You can always ask when changes are being proposed and discussed. When they are talking to you about medication and titration or tapering medications, how are you going to come up with this medication? How are you going to go about this medication? When are you supposed to call us? When are you supposed to contact us? And what am I going to expect from this medication? I bring this up because, it may come to a surprise to you that how many times we get phone calls that there was this huge miscommunication. We had, for example, had started a patient on one of these new headache medications. The patient took one dose and it stopped taking the medication, that it didn't work. Telling the patient that these new medications or medications that prevent headaches in general can take, several months for it to work. And you will not see any benefit just with one dose. So what do I expect from these medications? Should consider asking all those questions, especially when they're starting you on a medication. What is interesting, I was looking at a study, although there are many other studies that talk about how much patients remember after their visits. So there's this one, I just looked at this one study that they look at patients have had their ambulatory or clinic visits, outpatient visits. They look at this specifically about almost 190 patients, and they talk to these patients about 1 week after they had had their visits with their physicians or the clinic. About 49% of patients, although I have looked at other studies, this seems a little bit of overestimation to me, but for this study, about 49% of the patients remembered what was discussed in the visit. And they go, yeah, this was discussed. About 36% of the patients, they had to be prompted. When they were prompted, they remembered what was discussed and what the plan was. 50% of the patients didn't remember accurately or didn't remember at all, even after being prompted. I say that because I come across this so many times. I'm going to give you an example. We had a patient in our clinic on Thursday, had called Dr. Loeb with increase in seizure frequency, and Dr. Loeb had added a second medication. This was, 3-4 months ago. When I talked to the patient on Thursday, she told me that she wasn't taking it anymore. And I said, why aren't you? And she was telling me she was having a still seizure. I said, why aren't you telling it anymore? And she told me that, I thought Dr. Loeb had started me on for something else. Or I think what she mentioned was for muscle relaxant or something. I said, why would Dr. Loeb, your epilepsy physician, start you on that medication? It was for your seizures, and this miscommunication that you had to take it and you have to take it regularly. So that's really, really important. And I see that all the time. When in doubt, ask. So you might not be familiar with having a clinical pharmacist around, but I can tell you that in the hospitals, they are always on the floor, especially if you go in the big hospitals, they are on the floor. You can always ask, can I talk to a pharmacist? In the clinics, there are many clinics that pharmacists are there. You just have to ask. As I said, neurology, if I am in neurology and it's not the most common place for a clinical pharmacist to be in, there are pharmacists in many other areas. So in a clinic, you have a question about your medication, you can always ask, can I speak with a pharmacist? Many medical centers and hospitals, what they have now is called this MTM, which is really huge in pharmacy, medication therapy management pharmacy. Your physician can refer you to. I mean, when we have patients who are on multiple medications, they have, they have diabetes, they have elevated blood pressures, they have epilepsy, and they're really struggling or management of this, we refer our patients to our MTM clinic. And there are pharmacists there, and this is all they do, management of patients' medications, making sure that patients are taking medications appropriately. So you can always ask if that's a challenge, is an issue. But again, in my, experience, asking questions when you're in doubt, or taking written instructions before you leave the clinic and all that, I think it's just very, very important things to consider when you see your physicians. And I think, Julie, that is my last slide, and I'll be happy to answer any questions.
Mitra, as always, I learn more and more from you every time. Thank you. Thank you.
Well, I'm happy about that.
Yes. No. I love this whole team thing, the MTM thing. This is so important because there's, because we're not just one piece and we have multidisciplines. I know we get a lot of questions about that at the foundation, and to know that there's somewhere to go is critical, because, with ADHD meds and all the other things that go into being, it's such a critical part. So thank you.
You're welcome. You know what is interesting, Julie, that even outpatient pharmacists have started doing that. Pharmacies like Walgreens, not every store has it, but this is becoming so popular, you can always ask.
That's awesome.
But this is becoming so popular that even outpatient pharmacies, the standalone pharmacies are setting it up.
Great. Awesome. Well, we have some questions in the box. So
Okay.
It looks like we have here, which seizure drug is similar? And I can't ever say that, the generic of Keppra.
Oh, levetiracetam.
Yeah, you got it. I heard there's a new drug with less behavior and mood side effects. If my daughter has done well with that very long word, would she do well with seizure control with a similar drug, thinking about changing to a different drug?
Well, its cousin is called beriveracetam or Beriviact. It is in the list, and I can send you the list, Julie. Juliet, you can have the list. It's on the list. Beriviact or beriveracetam. It's a cousin of, very similar, as you can tell from the name, levetiracetam, beriveracetam. It's very similar. So it's not completely the same, but I will say that it's similar. So if she's done well, and you can always ask the epileptologist, would the other drug be a consideration for your daughter? So they are similar.
Great, thank you. And can antibiotics, we get this question a lot too, can antibiotics like amoxicillin interact with the seizure medicines like Keppra and Tegretol?
Well, Keppra doesn't interact with any drugs. So that's a nice thing about Keppra. And one of the reasons that, in many times physicians start patients on Keppra or emergency rooms as Keppra, because they know that they can do no harm. If the patient is on other medications, Keppra is not going to do any interactions. Now, carbamazepine is an inducer, as one of the drugs that is a very strong inducer. So it has a tendency to diminish, not every single drug, diminish activities some of the other medications that are there. I'm going to quickly look at, from the top of my head, I don't remember amoxicillin, but if you give me a second, I'm going to look at it while I'm talking to you, because all I have to know, I know what carbamazepine does, and all I have to know is how amoxicillin gets metabolized, and I can tell you for sure if it does or doesn't. No, it doesn't. So the way amoxicillin gets metabolized doesn't do anything, carbamazepine doesn't do anything with it.
Awesome. And they asked you, Keppra interact with an antihistamine? No.
Keppra doesn't interact. Now, the antihistamine, this is the issue, because Keppra can cause sedation, right? Although if you have been, the sedation part or tiredness part of these medications is usually in the beginning. Our body is amazing. We get used to this. Otherwise, patients wouldn't be able to take these medications. That's another reason that we start the medication slowly and we go up. We are giving the body time to get used to this medication. The interaction between Keppra and antihistamine is not at the level of drug-drug interaction per se, that they do anything to each other. Is that they both cause sedation. So if you're already experiencing sedation or sleepiness with Keppra, if you add antihistamine, then you're adding a second drug that, so you may experience that more, but they do not do anything to each other.
So then we have another question about Keppra, lacosamide, Epidiolex, and oh boy, rufinamide interact with each other. So there's 4 drugs there.
So I can tell you, without looking at all of them, yeah, there's a very good possibility it's this drug because your list is very long. And these drugs, Epidiolex has a tendency, yes, there are drug interactions, but Epidiolex, Keppra, you can take Keppra out of that equation, because as I said, Keppra, Keppra uses our kidneys to get excreted unchanged. Keppra doesn't get metabolized. There are no drug interactions. So Keppra is out of that scenario. But I'm going to tell you this, the drug interactions do happen. But the person, the epileptologist, the neurologist who's prescribing it knows it. So just because drugs do interact with each other doesn't mean that you cannot take them. So what they are doing, and we are combining these drugs all the time, and our patients are on these medications, how we manage it is what their doses. So we manage their doses, we give them appropriate doses, we check their levels. So just because drugs interact with each other, otherwise you wouldn't be able to take any of these medications because they do interact with each other. It doesn't mean that you cannot take them. And as I said, the monitoring, the appropriate dose, they all come at the level of your physicians and your healthcare team.
Mitra, one question, and I wanted to just ask it this way because a lot of times we'll hear at the foundation that they want a drug taken away because of side effects, but a lot of our kids are on 2 and 3 drugs, but we take one away and they see all new side effects. Do you see that being an issue? I know we saw that in my daughter with phenobarbital and Keppra, for instance. She was very sweet, lovely, and all of that, but we took the phenobarbital away and we didn't realize that this whole new child would emerge. We thought this would, we were so worried about seizures. We weren't worried about the behavior necessarily. And we were able to curb it. But I think sometimes it's good to know that even when we take things away, other things might emerge.
Well, a lot of our medications, I shouldn't say a lot, a good number of our medications are mood stabilizers, right? So you take that away, and that's where the mood issue comes out. These medications that I am thinking of, and I can give you the names, these medications are first anti-seizure medications, and then psychiatry has been using them, studied them, using them, and they have used, they can use them as mood stabilizers. For example, valproic acid is one, carbamazepine is one, oxcarbazepine is one. Phenobarbital has this calming effect. It's a barbiturate. So you took that away, and then all of the other issues that your daughter had, they come to surface. Yes. So when you're taking those medications away, you have to be careful. Yes. And we have, as I said, a good number of our medications are considered mood stabilizing medications. And when you take them away, you should always have that consideration that what's going to happen when this is not there.
Absolutely. 2 more questions, and then I promise I'll let you go.
Okay.
Does Lamictal interact with antihistamines?
No, again, you have to remember, we're talking about 2 types of interactions. The interactions that this drug either increase the metabolism of the drug, that's the concept, or decrease the metabolism of drugs, that they're interacting with each other at the level of, I don't want to get too technical, I'm not taking to get too technical. And there's another type of interactions that I just talked about, that they increase the adverse events of each other. For example, both of these medications are sedating medications. Lamotrigine can cause sedation, especially in the beginning when you're starting it, and then antihistamines are quite sedating. So when you add them, there are no drug interactions with each other. You can use them. Again, I'm going to tell you this, there are hundreds of thousands of medications out there. Majority of them interact with each other. Just because drugs interact with each other doesn't mean you shouldn't take them or you cannot take them. If you ask your physician and you ask and say, these drugs interact with each other, and she says, yes, it doesn't mean that you cannot take them. It's just that, as I said again, it's just that they have to dose it appropriately. So I don't want to give this impression that you guys all have to stop any drugs that interact with each other. That's not the case. To answer your question, you should watch for increase in sleepiness if you're going to give antihistamine. It doesn't mean you cannot use antihistamine if you need it for that period of time. You may use it for something that you need to use it. It's just that you should expect that she might be or he might be more sleepier, and that's the reason.
Absolutely. And then finally, how long does it take for someone to adjust to new medications, and how long do we try them to see if the side effects subside? And with that, they also ask, do some of these drugs eventually stop providing the seizure control? And is there a certain time in a child's development that this can occur? So,
Well, I'm going to go, I remember the last question, so I'm going to go backwards. Can they lose their efficacy, which means they stop working? Yes. And for some patients, yes. And I've seen it, and I'm sure you ask anyone and they say, yeah, the drug hasn't stopped working. Can it happen? Absolutely. And then Julia, what was the second question? Sorry.
oh, that's okay. It was, how long does it take to adjust to new medications? And
so
then, yep, go ahead.
It depends on the medication, and it depends on the patient. It depends on you, and it depends on the medication. And we know, for example, we know some medications have a specific adverse events. For example, we know some medications tend to be causing more sedation, more sleepiness. We know which ones they are. So it depends on you. And I start a patient on a medication, and they come back and say, oh, no problem. I had no problems taking this medication. Give the same dose to another patient, oh, I cannot take this medication at all. So it depends on, there is no one rule for a medication. It depends on the person and the medication. And everybody's different.
So in other words, we should be patient sometimes too, right?
Right. As far as adverse events, I think there was a question here about adverse events.
And how long do we see if side effects subside? Or
so how long does it get for some? But let's say the most complaint that I hear when you start the medication now, if a patient has an allergic reaction, you should stop the medication right away. Skin rash, allergic reaction, that's a different story. Stop the medication and call your physician. But if you're talking about the sleepiness, I'm not feeling too good on it, it makes me tired, that gets 95% of the time, that gets better with time. Now, how long is it going to take? Again, I wish I had a specific answer for you, but again, every patient is different. Usually, for example, we start a patient and we see them, in the next 2 months, the next 3 months. By the time they come back and see us, they say, yeah, in the beginning I was a little bit sleepy, and then now I feel much better. So I would say in that period of time, but again, every person is going to be different.
Absolutely. Mitra, thank you.
You're welcome.
The best as always.
You're welcome. Thank you so much for having me.
Of course. And I think we learned a lot today.
Fantastic. Have a good afternoon. Bye, guys.
Bye-bye. All right. So it looks like my friend Craig Burkhardt is here. This is very exciting. I haven't seen you in a while.
Hi, Julia.
Hi, how are you?
Very good.